This is the last lecture in the unit on justice and healthcare reform. Today we'll be considering two alternatives to Obamacare, alternatives to the Patient Protection and Affordable Care Act. Both these alternatives attempt to address some of the significant problems in our healthcare systems, problems which we have seen have significant moral implications. The first lecture in this unit identified the moral principles relevant to an evaluation of our healthcare system. I suggested there that the principle of beneficence, which requires us to act in ways that promote people's welfare, means that we must ask whether our healthcare system effectively and efficiently protects us from the ravages of disease and injury, and, of course, the suffering, the debilitation, and the premature death that those ravages produce. We have considered evidence that our system is deficient in this regard, that it is costly, and despite those high costs in comparison to other comparable countries, our healthcare outcomes, measured typically in terms of things like life expectancy and infant mortality rates, those outcomes are not better in comparison to other comparable countries. I have also suggested that we must ask whether our system is fair. That is, do people get the health care they deserve? This obviously relates to the principle of justice. Many people believe our healthcare system is unfair because millions of us lack access to the system because they don't have health insurance. They don't get it through their jobs as an employment benefit, or they're not eligible for federal programs like Medicaid and Medicare. And they're too poor to purchase health care insurance on their own. It's not fair, many folks would argue, that so many people lack access to our system. It's not that they don't have any access entirely, but it's that that access is through emergency rooms, which means that people often wait far too long to present, and they seek care when their needs can only be met in the most expensive way possible. We have considered the possibility that justice requires better access to health care for those millions who lack insurance. We have considered arguments for and against the idea that there is a right to health care. We have also looked at Obamacare, or the Patient Protection and Affordable Care Act of 2010, as an attempt to address some of these issues. That controversial law tries to address issues related to the quality of care by requiring more comprehensive insurance coverage and to control cost by a variety of managed care reforms. It has tried to increase access to care by expanding Medicaid, requiring large employers to provide insurance, helping smaller ones to provide such benefits through subsidies and tax credits of various sorts, and requiring uncovered persons to purchase insurance with help for those subsidies, for those who need such subsidies to buy care. Now, the evidence suggests that Obamacare is surely expanding access, but whether it will be able to control costs remains to be seen. In this final presentation, we're going to be looking at two alternatives to Obamacare, two different attempts to address the problems associated with our healthcare system. One is from the left, more liberal, and it's called a single-payer national health insurance approach to healthcare reform. The second alternative is from the right, or more conservative, and it represents a market-based approach to improving the quality of care and improving access. Let's look first at the idea of a single-payer national health insurance approach to healthcare reform. In our textbook, the article by Heimelstein and Woolhandler, called National Health Insurance or Incremental Reform, describes and advocates such a plan. The article by Ezekiel Emanuel, The Problem with Single-Payer Plans, critiques such a proposal. The second page of the Heimelstein and Woolhandler article lists the key features of their proposal. I'm going to refer first here to the two features that are essential to any single-payer national health insurance plan. First, they argue for a system that offers universal comprehensive coverage. This means that everyone, presumably they mean all U.S. citizens, would be covered, and the plan would cover a full range of healthcare needs, including dental, mental health, and long-term care, such as nursing home care at the end of life. Secondly, they refer to a single insurance plan in each region, administered by a public or quasi-public agency. This is what makes such a system a single-payer system, as opposed to the one like we currently have, where there are hundreds of individual insurance companies alongside government-administered programs like Medicaid or Medicare. This is essential, they say, because, quote, a fragmentary payment system that entrusts private firms with administration ensures the waste of billions of dollars on useless paper pushing and profits, unquote. These are common to all single-payer national health insurance plans. Heimelstein and Woolhandler, however, advocate a few other features which seem not to be essential. First, they would permit no for-profit hospitals or supplemental insurance plans providing better or more extensive coverage over and above the national health insurance plans. That is, they would not allow what's called a two-tiered system, though this is what the United Kingdom or Great Britain has as part of their national health insurance plan. Secondly, they argue for no out-of-pocket payments by patients, that is, no co-payments or deductibles. Now, co-payments means that the individual must pay some small amount for services while the insurance plan pays for the rest. Deductibles refer to a requirement that patients pay so much in overall cost before insurance coverage kicks in. Both have been thought to help control costs by making sure that persons give some consideration to the expense of care before seeking it. They also argue for free choice of providers, that is, a system in which patients are free to seek care from any licensed healthcare worker. There are some other features they name, but I think these are the most important for you to be familiar with. Now, what moral reasons do people offer for such an approach? First, and most obviously, such a plan aims at guaranteeing equal access to health care for all. It's perfectly equal for all in a proposal like Heimelstein and Woolhandler's. But even in plans that would allow those who could afford it to seek additional health care coverage, more extensive insurance plans from for-profit institutions, there is at least a guarantee of equal access to an extensive range of necessary health care. For those who believe that justice demands equal access, or that everyone has a right to health care, this is surely a major consideration. Even if one's argument for broader access to health care is grounded in the weaker claim that governments have a responsibility to promote the welfare of its citizens, grounded in beneficence rather than justice, a single-payer national health insurance plan is attractive. It's grounded in the common-sense belief that people's welfare will be improved if they have access to health care services when they are sick or injured. Secondly, however, proponents of such a system believe that it will significantly enhance the efficiency of our healthcare system, freeing up resources currently spent on healthcare for other things that could enhance human well-being. This is a major argument advanced by Heimelstein and Woolhandler. They note that bureaucracy now consumes 30% of our healthcare budget, and that private HMOs keep 20 to 25% of what they take in for overhead and profit. Now, in comparison, Canada's national health insurance plan has only 1% overhead, and even Medicare in the United States, a government-run program, shows only 4% overhead. Reducing overhead in the U.S. system to Canada's levels, they insist, would save $140 billion annually, and more than offset the additional taxes required to finance a national health insurance plan. So instead of huge payments of money to insurance companies, we will be paying a reduced amount in higher taxes. While Hammelstein and Woolhandler don't mention it, you should also recall the argument by John Green that healthcare costs have skyrocketed in the U.S. because none of the multitude of payers for healthcare, even the government, has the negotiating power to drive costs down. He argues that a system like Canada's and the UK's are able to do that because the National Health Plan is virtually the only purchaser of healthcare. You don't get their contract, you simply aren't in the healthcare business. While Hammelstein and Woolhandler don't mention it, I think most proponents of a national health insurance plan would argue for progressive taxation to pay for it. That is, that the more well-off will pay a higher percentage in income taxes to support the national health insurance plan than do the lower-income persons. So this would address the growing gap between rich and poor that we've talked about previously. It would represent a redistribution of resources from the top to those in the middle and at the bottom of the income and wealth scale in the United States. And other healthcare providers, because of the reduced time they are able to spend with patients. And that largely a result of the amount of time they spend filing paperwork necessary to meet the demands of and the oversight of multiple providers, insurance companies, and government programs as well. Hammelstein and Woolhandler suggest that their plan would address this issue by significantly reducing that paperwork to meet the demands of one. Okay, you should certainly pay careful attention to Ezekiel Emanuel's essay, The Problem with Single-Payer Plans. Emanuel is the brother of Rahm Emanuel, who was President Obama's chief of staff and is now the mayor of Chicago. Ezekiel Emanuel was a major architect of Obamacare. He notes that single-payer plans do clearly provide universal coverage, and he agrees that they enhance the efficiency of healthcare financing by eliminating the wasteful costs of insurance underwriting, sales, and marketing. But he is dubious of its overall efficiency, its overall ability to control healthcare costs. Let's see why. First, he argues that single-payer plans preserve the fee-for-service delivery system that we've seen have long been a primary driver of rising healthcare costs in the United States. Now, I'll be quite frank, I don't understand this criticism. Indeed, my assumption would be that a single-payer national health insurance plan would incorporate the practices associated with managed care, especially the coordination of services and the negotiating and limitations of payments for services associated with diagnostic-related groups, or DRGs. Secondly, he notes that the administrative savings associated with single-payer plans are deceptive, he says. The saving gained by reduced paperwork is lost, he says, as a result of fraud. He notes, for example, that a 1996 assessment of Medicare found $23.2 billion in improper payments due to insufficient or absent documentation, incorrect billing, and other problems. This, he notes, represents 10% of overall payments under Medicare. I would make several points in response to Emanuel. First, I understand Hammelstein and Woolhandler's claims about saving to be related to the elimination of multiple layers of reporting requirements and duplication, where there are hundreds of different payers to whom a physician or a hospital must report. Moreover, as Emanuel himself notes, nothing would absolutely prohibit single-payer plans from spending more money on administration to detect fraud, improve computerization, address payment issues, and assess quality. That is, improve all that within the single-payer plan. Nothing, he says, that is, prevents this, but a strong ideological commitment to keeping administrative expenses very, very low. But I would ask, isn't there an equally strong ideological commitment to avoiding fraud, especially within a system in which everyone has a stake and which all depend upon and all pay for? Third, Emmanuel is dubious about the ability of single-payer plans to address the other drivers of high healthcare costs, such as overutilization of more and more increasingly expensive technologies. He notes the two ways such costs can be controlled. One is to constrain the supply, as he says. That is, reduce the introduction and availability of costly technologies, producing service bottlenecks and waiting lists for services. Surely this is a complaint that one often hears about national health insurance plans in Canada and Great Britain, although the defenders say those waits are only for elective procedures, not truly necessary ones. Now, Ezekiel is certainly correct that an issue any single-payer plan will have to address is precisely how extensive the guaranteed coverage is and how many resources will be put toward making those services available. Now, Heimelstein and Wuhandler reject a two-tiered system, but one way to reduce costs is to provide less than fully comprehensive coverage and services in the National Health Plan, but allowing those who are able to afford it to purchase additional coverages and services, thereby enabling those with resources to avoid possible delays and reduce pressure within the National Health Insurance Plan. Finally, Emmanuel notes that another way to control costs is to lower payments to for services to physicians. That, he notes, is an important part of what forces physicians to see more and more patients, giving each less attention. And, as we have seen, this is part of what is already happening that makes the role of a healthcare professional less and less satisfying. While Emmanuel is not wrong here, it does seem to me that a couple of things can reduce this concern. First, more resources going into medical education to reduce the debt that healthcare providers face as they go into their practice could help the need for physicians and other healthcare providers to generate high incomes. Secondly, physicians may over time get used to lower incomes than they have come to enjoy, especially as those incomes shot up during the fee-for-service period between World War II and the 1980s. Okay, let's take a quick look now at market-based approaches, or a market-based approach to healthcare reform. I've made available to you a brief article from the Cato Institute called 5 Ways to Solve Healthcare by Michael Tanner. This article was written a few years ago and just before the Supreme Court decision upholding the constitutionality of the individual mandate. As I told you, Obamacare is facing a new legal challenge related to the funding of the subsidies for those required to purchase health insurance under that mandate. This article is referring to the earlier challenge. Now, notice his introductory comments. He says, quote, "The U.S. healthcare system has much to recommend it. We produce most of the research, innovation, and technology that improve healthcare throughout the world. Americans have more choice of physicians and treatments than patients in other countries. And if you are sick, your chances of survival are far better in this country than elsewhere. But one only has to open their latest insurance bill to see that the cost of healthcare is still going up. At the same time, too many Americans remain uninsured, although the number of uninsured is often exaggerated by critics of the system." Unquote. Now, I think it's fair to say that the Cato proposals are aimed at protecting the high quality of care that is available, reducing costs, and expanding access. Although I think it fair to say that Cato, which promotes a libertarian conception of justice, rejects the idea that justice or rights require such access. I think it's also fair to say that the proposals are largely grounded in Cato's and Tanner's libertarian commitments to the widest possible range for individual liberty. So, with that in mind, let's look at their 5 ideas. First, Cato and Tanner would like to see health insurance as something one buys individually, rather than getting as an employment benefit or a government entitlement through Medicaid and Medicare. There are several reasons for this. First, and most significantly, I think Tanner believes that individuals not having to make their own decisions about health insurance by making a purchase decision themselves produces overutilization that drives up costs. Here's what he says. Employment-based insurance distorts our healthcare system in several ways. Most significantly, it hides much of the true cost of healthcare to consumers, thereby encouraging overconsumption. If workers believe someone else is paying for their health care, they have less incentive to be frugal consumers. People naturally eat more at the all-you-can-eat buffet than if they have to pay a la carte. Secondly, Tanner notes correctly that employment-based insurance lacks portability. That is, if you lose your job or change jobs, you lose your coverage. And if you have a pre-existing condition, you may not be able to purchase coverage. Of course, this danger has been eliminated by Obamacare. Tanner argues that this shift would reduce the cost of health insurance and thus make it more affordable, and cites a study that suggests this would result in 21 to 27 million more with health care insurance. That's nearly as many as Obamacare promises to cover eventually. It seems to me that it should be noted here that the cost savings estimated are based upon our being forced or constrained by the resources available to us as individuals to forego health care services we might otherwise utilize if our employer were bearing the costs. Tanner's predictions of lower costs seem surely right, but it seems not to recognize what the President's Commission pointed out in making its argument for greater access way back in 1983. They noted that health care needs have a special moral significance. That is, they are truly a need, not a want, because of their relationship to what I've referred to as our physical nature and our vulnerability to illness and injury. Secondly, the President's Commission, you'll recall, noted that it's implausible that individuals could meet their own health care needs, given how costly they are, given how unpredictable they are, and how unevenly they are distributed. This then seems to me to raise this question. Are health care needs in a special category that means it's preferable to separate them out from other things that human beings need, want, or desire, and make them as free as possible from the sort of balancing between desires and resources appropriate to other products and services? Now, I'm talking, of course, about freedom from that balancing for the individual. Obviously, a society as a whole under a single-payer plan has to find that balance. Don't be deceived by the claim that national health insurance makes health care free. It's only free to the individual at the point of delivery, but massive taxation is required if those services are to be available. So, still, one should ask whether it's the individual or society as a whole that should be doing that balancing, given the uniqueness and the special significance of healthcare needs. The second of the Cato proposals for reducing costs is to increase competition and break up insurance cartels. Of course, it's not simply the reduction in utilization that Tanner sees as a factor that could push insurance costs down. As well, he would eliminate restrictions that prevent people from buying insurance plans in other states. This would increase competition and also help to drive costs down, improving both efficiency and access. I think we see here a proposal based on a very different understanding of why healthcare costs are so high in the United States than John Green's. What Cato and Tanner are suggesting is that it's precisely the absence of true competition among insurance companies because of the various restrictions of trade between states that keeps prices high. Surely there's something right about what Tanner suggests here. In theory and in practice, competition among insurance providers drives the price of insurance down. Of course, Green is talking about something else entirely that the Cato proposal would not change. The reality of multiple purchases of healthcare services, that is, multiple insurance companies, none of whom has the power to drive prices for services they must purchase for their customers, down. In theory, competition among various healthcare providers, physicians, hospitals, developers of medical technologies, and pharmaceutical companies should be the force that drives those prices down. Presumably, Tanner and Cato would advocate a much less regulated marketplace in this domain as well, which would contribute to price-reducing competition. Two questions are crucial here, however. First, are there natural barriers to entry into this competitive field? High startup costs for firms, demanding and costly educational requirements for professionals, all of which limit competition among providers. And secondly, in a domain where the need being addressed is so fundamental and where mistakes are so costly, is deregulation to produce competition consistent with other important considerations? That is, are individual consumers able to protect themselves in this area, or is government regulation necessary for that protection? Tanner makes is to have seniors make their own Medicare decisions. He would eliminate what he says is basically a fee-for-service approach under Medicare, an approach that we know rewards doctors for greater utilization of services. And he would replace that with a voucher system where the elderly are provided a set amount by the government, and then they would decide how to use that money to meet their medical needs. Again, it seems to me that Tanner fails to recognize the unpredictability and uneven distribution of healthcare needs. It may seem perfectly fair and equal to give every senior the same resources for purchasing healthcare services. Unfortunately, healthcare needs are not distributed equally, but vary radically from person to person. Finally, he proposes experiments from state to state to help control Medicaid expenditures. The Medicaid program for the poor is costing billions of dollars, and he says at the same time the program is notorious for providing poor care because reimbursements are so low. Nearly a third of primary care physicians will not accept Medicaid patients, driving recipients to hospital emergency rooms for treatment. In fact, Medicaid patients are more likely to end up in an emergency room than those with no insurance at all, unquote. As a remedy, he suggests that the federal government return funding and responsibility for the program to state governments in the form of block grants and allow states to experiment with ways to control costs. It's interesting to me that though the libertarian ideology that undergirds the Cato proposals might seem to call for the elimination of publicly financed programs for the elderly and the poor, this is not what they propose. This leads one to suspect that their proposals related to Medicare and Medicaid represent a calculated political appraisal that were they to make proposals perfectly consistent with their free market ideology, they would have no chance of gaining acceptance. Of course, everyone plays such political games. That's not to criticize Cato uniquely. It also seems ironic that the proposal notes the poor quality of care under Medicaid, attributing that to low reimbursement rates, but its proposal is aimed at limiting the funds that go into the program. Surely the Cato proposals illuminates an unavoidable issue, the high cost and the heavy tax burden that public provision of health care for the elderly and the poor imposes on us all. And they are right, surely, to make us aware of that high cost. Well, that concludes our discussion of alternatives to Obamacare. Surely there are no easy answers to the challenges represented by the deficiencies in our healthcare system. Hopefully this unit, though, has given you a comprehensible introduction to the ethical issues we face as we think about that system. Hopefully as well you understand in broad terms at least the various kinds of policy proposals before us for addressing these concerns. Above all, I hope I have convinced you of your responsibility to be a part of the public discussion about how to move forward with the reform of our healthcare system. Hopefully what you've learned will empower you to be a more effective participant in our efforts to make our healthcare system more effective, more efficient, and to think more carefully about why and how access to that system for all could be expanded.